Hello everybody, this is Margareta Harris in WHO Headquarters Geneva, welcoming you to our global press conference on...
One is through the contact tracing. And there are some countries that are testing all of their contacts, and they're doing really detailed case contact investigations. We have a protocol that we have released called the FFX, the first few X cases, or the first few 100 cases, which we've developed over the last 10 years with many partners, including in the UK. They use this study regularly for flu. Where you test your cases and you test your contacts. And then you look at what is the attack rate, what is the, how often is transmission occurring between a known case and the contacts, and then you follow those contacts onwards and onwards. And that's a really detailed investigation. That doesn't have to be done in every country and in every location, but if that type of study is done in a handful of locations really, really well, we can get detailed information. Another type of investigation that can happen are called outbreak investigations, where you have these clusters. So for example, if you're having a cluster in a closed setting, we've seen some really, really detailed studies in the expat dormitory outbreaks that were happening in Singapore. And in that situation, they increased their testing capacity to look at the extent of infection in that population. And there, they broadened their testing to look at where is the virus and who has this virus. And in that situation, have identified asymptomatic cases as well. So again, there are different types of settings, there are different types of studies that can be done that could help us to better understand this. But really testing everybody on the planet, it's just not feasible. So what we focus on is finding the active cases. If we really start with the symptomatic cases, even if we start with those and we do a really good job of testing the symptomatic cases and you isolate them, you find their contacts, there may be some cases among those contacts. We know that the reproduction number, if left to spread, could be 2 to 3, so you may find additional cases among those contacts. If they are quarantined, we break those chains of transmission. Then you can follow. So I think there are lots of different ways that we can get this information through specific studies, but just to reiterate, they don't have to be done in all countries all over the place. If they're done really well in a handful of locations, we can get detailed information about how many asymptomatic infections there may be, and then we can make some estimates, and then we can look at transmission from asymptomatic individuals, from pre-symptomatic individuals, and from symptomatic individuals. And in fact, those studies are being published now. So there are really good studies that are coming out looking at addressing this.
Thanks, Maria. I think Dr. Ryan has something to add here.
Just to support what Maria said, I mean, the primary function is to test symptomatic cases, but the tactical use of PCR-based testing to expand investigation around a case and to test contacts of a case can be used to try and shut down transmission. And if you have relatively low-level transmission in a country and you have hotspots, then you can deploy your testing tactically in order to support a more intensive testing regime in a particular area for a particular purpose. But that testing has a purpose. The purpose is to shut down a known cluster, a known chain of transmission or chains of transmission in a given area. Broad-based, population-based testing, just on, like a screening testing for everybody, is, number one, very difficult to achieve. Number two, will absorb huge amounts of resources. But it's not impossible, but in the current context of the availability of testing, if we can't test enough people now who are symptomatic and we can't get those results back within a day and we can't investigate those clusters, then the value of doing that type of testing, which might be totally inefficient, is problematic. However, there are newer tests coming online, and certainly some of the newer antigen-based tests, these more rapid tests that can be done at home, and Bruce may speak to this. We're working through our lab networks and working with the ACT Accelerator and the Diagnostic Consortium in the Accelerator with the Group FIND and with the Global Fund, looking and evaluating antigen-based tests, which are much more easy to administer, can be done at home. And in a situation like that, if we can get to having cheap, widely available, validated, reliable testing, then we could introduce broader-based testing as part of our tactical strategic response. We're not there yet, but Bruce may want to comment on how soon we may get there. But none of this comes cheaply, and all of this testing costs. And many countries simply do not have the resources to expand their testing to everybody in the population. Bruce, you may have a follow-up on that.
Dr. Aylward does have a follow-up.
Well, I do now. Thanks, Mike. I think the worst thing that could come out of a conversation like this is a headline that says, global testing not feasible, because that's not what we're saying. What we're saying is global testing is not the efficient way to tackle this disease. And we want to be efficient and go after the virus, as we've said repeatedly, and Mike and Maria have laid out so clearly. And also, remember, broad-based testing, if you know your cases and you've got a quarantine and a tracing system in place, it's unnecessary as well. There are other ways to chase and find who is infected with this. And finally, it can be problematic because for the reasons I think Maria mentioned earlier, people have a sense that, okay, great, I'm not infected, when in fact you're incubating the virus as well, right? It gives you a picture at a point in time. So we've got to, again, we've got to be smarter than the virus and use all that we know about it to trace, track, and then break those chains of transmission. And to Mike's point, we've relied on PCR, and you've heard all the problems that we've had. It's hard to scale sometimes, especially when you have really intense transmission in an area. So one of the things that, one of the big thrusts of the ACT Accelerator has been to try and evaluate all those tests that are coming out. And there's some great work being done by groups like FIND, the Foundation for Innovative New Diagnostics. And what they're trying to do is evaluate every one of these in different settings to try and identify among this huge number where are the real gems that are going to give us the kind of breakthroughs we want in this rapid testing. And the last couple of weeks, and you may have seen some announcements in the news over the last couple of days, it looks like, from our side, there may be some tests now that are hitting the level of sensitivity and specificity that you can get much more rapid testing. We hope to get those more operational testing of those, and certainly later this year, beginning of next year, to really get a big shift in how we can expand testing and make it more rapidly available. It'll take a couple of months to get there, but the real trick was breaking some of the technical challenges to the rapid diagnostics, and that's looking better. But even then, we want to be clear, right? Because people often compare these like to a pregnancy test, and think about it that way. Who takes a pregnancy test? Well, people who think they might be pregnant. I haven't taken one and probably won't. But the reality is, similarly with these rapid diagnostics, you really want to be targeting them to people who may be infected or may have been exposed. This is where you're going to get the bang for your buck. So you really want to be as efficient as possible. It's not only an issue of feasibility, it's really an issue of efficiency when you're chasing a virus like this.
Thank you very much, all three doctors, for excellent answers. We are